myself organized here. Yes.
Okay. Sorry. Please. Okay, hi everyone. We're going to get started in just a second. Dr. Yaffe and Dr. Williams will deliver brief remarks, and then we'll go to the phone lines.
Okay, ready to start? Okay. There's nothing on the screen, but okay. All right. Good afternoon, and it's Dr. Williams and Dr. Yaffe here to give you another update on how things are doing today. As I said before, we're into this time of intense adherence to our social and physical distancing, and everybody to stay home as much as possible, unless it's really urgent. But even then, we'd like you to consider using other methods such as virtual or telephone, and ways to avoid going out in the public if you can, because we're in this time where we're getting a lot more peak activity, as you're going to hear from the numbers today, of lab test positive, as we had anticipated this week, because it's the peak time of incubation for a number of the people returning from traveling and from high-risk areas. So as I said last week, over the weekend, and into this week until about Thursday or Friday, is especially an intense period for that, and we'd like people to be continuing to do everything they need to do to limit their contact with people within 6 feet, and also other methods of avoiding personal hygiene, hand washing, I should say, cover your cough, all those kind of things. And especially if you're ill or sick, to stay home, use the self-assessment tool to get information on whether you should be considered a COVID-19 case or not. And if questions, you can call your healthcare provider, and they continue to expand their services. So check with your primary care health unit and see if someone is available on the phone to talk to you, and they can give you advice on your personal situation. So we're opening up more and more means besides telehealth. The self-assessment tool, as well as primary care, are all ramping up to answer your questions and to deal with your concerns during this very critical time. So let's look at the numbers, and I'm going to hand things over to Dr. Yaffe at this time.
Okay, thank you very much. As of this morning, we have a total of 688 cases of COVID-19 confirmed in Ontario. This is an increase of 100 from yesterday. So the numbers are going up every day. Unfortunately, we now have a total of 9 deaths. That includes 2 more than yesterday. One of them was a woman in her 80s from Heritage Green Nursing Home who died in hospital. And the other one was an individual in their 80s who was a resident of Ina Grafton Gage Village in St. Catharines. And this person had close contact with a family member who had recently traveled to Europe. He died 11 days after he was confirmed to have the virus. Of the total cases, exposure information is still pending for 43%. So of those where we do know where they were exposed, 64% traveled outside of Canada within the previous 14 days prior to onset of symptoms, and 23% were a close contact of a case. In 13%, we have no history or travel or exposure to a case, so they were acquired in the community. Of those who traveled outside of Canada, 30% traveled to the United States, and the most common states were New York, Colorado, California, Florida, and Nevada. The next most common was 28% had traveled to Europe. In terms of hospitalizations, we are aware currently of 40 cases of COVID-19 who are hospitalized in Ontario. Of those, 17 are in intensive care units, and of those, 15 were on ventilators. So in terms of the lab data, our numbers, of course, are going up every day. We have over 10,000 that are still pending because the lab is trying to prioritize people who are healthcare workers or people who are in long-term care or homeless shelters or people in First Nations reserves or rural communities. And there's a lot of work happening to increase the lab testing capacity. Thank you.
Thank you, Dr. Yaffe. And I think from the overall standpoint, we've heard some more announcements from the federal government about enhancing their quarantine order. So it is effective for all travelers, not just symptomatic, but asymptomatic as well. And we're trying to get the details on how they're going to implement that at the various entry points, and how we're going to be giving that information to the provincial authorities, and what we would do as a follow-up in that regard. So, as I said, I was anticipating that this would happen, and now we're going to look at how we would implement that so that those coming back would be able to access, and we'd be able to contact them to ensure, one, are they able to do their isolation? And we want them to do that. If there's any problems that they need to address, we can help them assist that so they can maintain that isolation in their home setting as quickly as possible, and that means get back to their home location and set that up. And so our prerogative is to make sure we want you to do what you need to do. You need to do it now, and you need to do it consistently, and we're there to try and help you do that. So we need to get that information so we can set that up so that sometimes you come back and there's a sense like no one touch base with me. How am I supposed to get information and questions answered? So we want them to be aware of the self-assessment tool. Want to be aware of calling their primary care doctor. If they've been out of the country for a while, how do they do that? And also how do they contact telehealth? All the information we want to make sure and ensure they have, so that while you may be in isolation, you're not isolated from all the information you need to know to do what you need to do. So that's important. And the other aspect we looked at here is that on the national basis, cases are going up in all the provinces, some more than other. Some are dealing with some outbreaks of certain events. And they're all dealing with the same issue of, like we are, with a load of tests and some backlog as their tests and cases are escalating with more and more travelers coming back, and they're dealing with those issues there. It's interesting to note that they put out some national data, and how do we compare in that of those age groups of basically those 20 to 59 make up 60% of the cases, and those 60 and above make up only 31% of the cases at this time. And yet at the same time in the national data, at least that's the limited data they had at that time, of the hospitalizations, the rate of hospitalization is, on the overall data, just under around 6%, and the ones in intensive care venting is just under 2%. So it gives you an idea of the overall spectrum and picture across the country, and how does that compare with some of the other countries that you're seeing the rates much higher in their respective jurisdictions. And it tells you that there's things that are unique to each setting, their demographics, how their systems are set up, and different challenges they have to face that are unique for their setting. And so when one is doing some comparisons, one should do so if they understand all the intricacies and different components of those before one wants to do some comparison and perhaps render some judgment who's better and who's not better. Until you're in that setting, you don't know what all the challenges are that those ones are facing. And in light of that, as Dr. Yaffe's talked about, we're still concerned with the situation of our neighbors to the south, as their numbers are rapidly going up with cases. Knowing that their population is 10 times ours, that's not surprising. At the same time, we need to be kept informed of what does that mean, especially those that are adjacent to our borders, and how does that impact our returning Canadian citizens at this time. The other thing, of course, yesterday was the decanting of Trenton. As I noted, it was well done by Red Cross and other volunteers, and by the military, again with their third cohort through. And there's just a few left, those that are still finishing off their period of quarantine because they had turned positive while at Trenton base in that regard. But it is important to note that of the ones that came back, there was 13 who had converted in that time, who were asymptomatic. One was became symptomatic on the flight, but the 13th came out of that number of about 200 odd individuals who had come off the cruise ship. So they're not without risk and exposure when they're in that type of setting, and we've alluded to that and asked people not to go on cruise ships at this time because of the high risk of the exposure site and things that need to be put in place to ensure any safety in the future. The other things that we continue to work on here is with the lab numbers. As Dr. Yaffe noted, yesterday we went up and we had pending an increase of 2,000 Today we had the same number of tests come in, but we didn't really move much. We kept the number, so we didn't accrue anymore, very much more. So we're continuing to make headway on that capacity, and we hope to keep pushing that as the week goes ahead, trying to get to our 5,000 a day in that number and in that setting. And unfortunately, as Dr. Yaffe has noted, we are still recording deaths. It is still in our high-risk populations mostly, and that is concerning. We continue to monitor as our health units work with outbreaks or cases, I should say, in long-term care facilities and other settings to make sure that it's walled off and dealt with quickly and appropriately as per our protocols and activity of the local public health units in that regard. But with the deaths, it tells you that this is not a non-issue. It's a very important one. The need to protect our vulnerable populations is as strong as ever. And my message, again, as much as everybody else has said, is that this time especially you need to stay home. You need to do the physical distancing, the social distancing, whatever your title and term is in that. You need to do it consistently. You need to do it with vigilance as well as your personal hygiene. And I haven't seen many aspects of people violent that. Sometimes there are that may choose to do so, and I would say with all the data and information we're giving you, and I think that Ontario citizens are highly responsible. And that's why I talk to you. I give you facts. I don't give you any rants and things like that myself. But I think I'm asking you to say if you do it, you know what to do. You can prevent it. You can protect yourself. It's not something that's mysterious. We've told you the evidence and the data around that. And if you're not doing that and you choose to do the activities, I would say that's foolish. Perhaps a better word is stupid thing to do. I think it's irresponsible and inappropriate for yourself, for your family, and especially for the vulnerable populations here. If we do this consistently over the next week or so, we think we can flatten the curve. And I'd like to think we could actually plank the curve, as I said before, that we talked about. Can we beat this? I think in Ontario we can beat this, but it's going to not without the full dedication of our citizens, and all you out there are doing what you need to do over the next number of days. And again, I've been really I'm thrilled with all the work that people are doing, the volunteerism, the media, the social media they're doing, the connecting, the very creative solutions you're doing to deal with this adjustment to life that is quite different than what we've experienced before. So thank you for all you're doing. Thank you for the media and different groups that are stepping up with lots of information and sharing so that while we're isolated 6 feet apart from everybody, it seems like people are connecting more and more with various electronic and virtual means. And that's great to see. So keep up the ideas and creation that way. Keep the distance, but keep connecting. So with that, we'll open up for questions.
Okay, we'll open the phone lines and we'll take the first question.
From Brian Lilly at the Toronto Sun.
Dr. Williams, I want to ask you about protective equipment. The Registered Nurses Association is saying that they are absolutely without the protective equipment that they need to do their jobs. They say that doctors and nurses are running short of PPE, and that ventilators are not going to be at the level that they need. Can you respond to the statement from the Registered Nurses Association of Ontario today, please?
Well, I think the Registered Nurses Association have done an excellent job and making sure they're checking with all their members throughout all the various settings. Some are in acute care, some are in long-term care, some are in home care, and various locations. And what we find is that the availability of personal protective equipment, some key parts, especially masks, and some aspects there are concerns in some areas that they don't have that supply. We have a lot of groups working at doing that. We've obtained a number of promised orders from the federal government in there. We get some donated materials. So we're working on all fronts to make sure that is there. The key, of course, we want to make sure those that are going to be dealing with the most problematic patients, that's the ones in the hospital, the intensive care units, that those facilities have what they need to do in the event they have a patient admitted and have to look after them. So they have a priority list in there. We're trying to look at our stock and inventory and all those settings. As you can imagine, it's a complicated supply chain issue, and we're working on all fronts to do that. If there's ones that are in situations where they don't have the proper equipment, then you need to talk to our regional Ontario Health Agency sections. There's offices and groups meeting, because if we don't know about those, then we can't deal with those needs at that time. So there's a lot of pieces out there. They all have to pull together. So I would suggest that they contact their regional office, and Ontario Health is ready to tabulate that and try to rectify it and deal with their matters in that concern. And the ventilator one, right now, excuse me, we have a lot of ventilators available. We've freed up room in some of the intensive care units as well as others. So we have some flexibility there now. It doesn't mean we're satisfied. We're going out trying to purchase others, and we're looking at, as the Premier announced, to have some of our people and creative industries here in Ontario to do some adjustments. And
hospital, how many people are on ventilators? So for yourself or for Dr. Yaffe, the situation in Quebec has gone from 0 to 60 in seconds, it seems. They've now got far more cases than we do. Montreal Jewish General is now, I'm told, well above capacity for ICU, for critical care. The Royal Victoria is not far behind. Can you describe the situation in Ontario in terms of the number of people that are in ICU, that are on ventilators, and do we expect the numbers, because you described that, we're getting to the point of we're about a week behind Quebec in terms of March break. Theirs was a week before ours, of people coming back from travel and bringing it back with them. So do you expect that we may be in a crunch period in the next week or so? So do we have enough now, and will we have enough in a week's time, or will the trajectory take us off course?
Months in ICU, if you have any numbers there, Dr. Yaffe, and I'll talk about the broader issue of the our so-called monitoring of the health system that we're doing from our command table. So, Dr. Yaffe?
Sure. So just to reiterate, so at this point we have 17 patients with COVID-19 in ICUs, and of those 15 are intubated or on ventilators. We are working extremely hard, basically day and night now, to get more supplies. And I believe we've recently secured an additional 300 more ventilators that have just been purchased, in addition to the 210 the province already has in an unallocated surplus. And that's just for ventilators. There's lots of other supplies as well, in addition to what Dr. Williams is going to talk about in terms of capacity now.
So the Quebec situation, and my counterpart there, Dr. Arruda, is dealing with a unique challenge of a very fast surge. Some of their lab results had been pent up because of waiting for, much like we did a while back with confirmation from the National Microbiological Laboratory. They've agreed that they don't need to confirm, so they went through the same quality check as we had done here at Public Health Ontario, and so they had a big jump all of a sudden in their numbers. Some of that was due to a backlog in that respect. As far as the hospital load in around Montreal area, I have not got detailed reports of that from my counterpart or from Quebec in general. I don't know the unique circumstances they're facing. I can say that with our command table and working with Ontario Health and our regional offices, that as we look at our data, with the assessment centres, our emergency numbers have continued to drop down. Our admissions from our emergency departments to hospital has dropped down. Our occupancy of our hospital, including our intensive care units, as one hospital said, this is an all-time 10-year low as far as occupancy is concerned. So we have created that space if we need to do it and when we can do it. So will it be necessary tomorrow, next week, or another day? We have to wait to see. But we're trying to compare for that with the equipment, but also with the space, with the staffing, and ensure all those things are ready when we have to move on it. So we are preparing. Are we satisfied just to sit on that? We're not. We're moving ahead with even more preparation. What can we have as alternative methods? If we do get a very severe scenario, we have to plan for that, hoping we don't have to do that.
Next question.
Rob Ferguson at the Toronto Star.
Hello, doctors. Thank you. I don't know, maybe Dr. Yaffe would want to take this because it's about her hospital staff. So I note the number of patients in hospital is up about double from Friday. and the number of patients is up as either on ventilators has either tripled or quadrupled since then, with half the patients almost in ICU. So what's that telling you about the way this is changing? Because it's ramping up fast in that sense.
Yes, I think what it's telling us is that there are more cases happening every day, and there are more cases that are severely ill. This partly reflects, I would say, who's being tested. And people who are mildly ill are generally not being tested. They're told to stay home and self-isolate. So it's not saying that the disease is getting worse. It's saying that we are identifying more severe cases. And of course, that's extremely concerning. We know that people over 60, which is really not that old in the scheme of things, are at increased risk. People with underlying illnesses like diabetes, high blood pressure, heart and lung disease, and so on. Immunocompromised people are at increased risk of getting severe illness. So we want to make sure that they are protected from getting infected. And so that's reiterating the message about everybody to try and stay home and social distance, and particularly keep in mind those who are more vulnerable to severe illness.
Follow-up?
Okay, thank you. And I would agree 60 is not as old as it used to be.
Yeah.
I heard on CNN some talk about home test kits for this. Are there actually going to be home test kits for COVID-19 at some point?
So I think what you're talking about is the point of care testing kits that have been promoted. There are, or rapid test kits too, both fit. A point of care could be in the physician's office, in a department, or in people could do it at home in some settings there. So they're being promoted. There are two types that are out there. One is a blood test. That means it's a serological test that tells you if you've had any immune response that's indicative of perhaps a COVID-19 infection. The challenge there is that those tests, at least talk to my consultants in the laboratory side, are about 50% sensitive. So if it's positive, it tells you something. If it's negative, it doesn't really tell you too much. And the other aspect is there, if it's positive, it doesn't tell you you're infectious. It just means that you might have been exposed to it sometime in the past. That's that one. The newer ones, the so-called similar to what we do in our labs, the PCR or polymerase chain reaction type technology, is coming out, but it's not out on the market yet. So we're waiting to follow up and see what happens there. So this is part of the evolving technology that back 3 months ago in December did not exist. So already by the end of January into February, when it just came on the scene, this is a really rapid ramping up of technology, and there's a wide variety of aspects there. So this is where the industry is applauded with coming up with ideas in a very short period. But of course, we want to make sure that what it's telling us, what is the quality of that, what is its specificity, and what is its sensitivity, so that we're not chasing false results and coming back on that. So again, it's evolving, and applaud the groups looking at trying to come up with these ideas, because we need all hands on deck on this issue.
Okay, thanks, Rob. We're just going to take one question from the room, and then we'll go back to the phone lines. Jamie, go ahead.
With the extra ventilators being purchased, with the being brought, all the extra equipment, all the support equipment, the protective PPE equipment, the overtime for everything from the nurses to the cleaners to the doctors, how much is this costing?
Well, that's a good question. The main thing is that very much support from the Premier and the Cabinet and the Minister of Health, the Deputy Premier, moving forward, as you've heard announcements, large amounts of funds to make available. We continue to look at covering those costs, trying to accrue and account for all those, because in the end we will have to have it tabulated. I don't have the numbers offhand. It's very early yet, because a lot of them are in place to be purchased and not purchased yet. So it's moving quickly, but still with proper approvals, with not long delays, because we have to move very efficiently at obtaining these products and materials. But as you heard, both from the federal government and from our provincial government, with the strong support of Cabinet and from the Premier, not holding back to say what you need to do, get it done, we'll cover it.
Okay, just one follow-up, Jamie.
Are we talking hundreds of millions of dollars, billions of dollars? There has to be a projection out there somewhere of how much this is going to cost our healthcare system.
Well, I think because we're getting funds also from the federal government, so it's a joint one. I know we're at least in hundreds of millions of dollars, and some of the numbers that were quoted by the Premier and money they're moving forward. And the total tally, I know the federal government's talking even larger numbers of what they've allocated even yesterday with their bill. And so they move large amounts, not as massive as some of the American numbers you see, but everybody's moving things to the forefront to bring this under control.
Back to the phone lines. Next question
is from Haley Cooper at News Talk 1010.
Hi, Dr. Williams and Dr. Yaffe. We're looking for clarification on transmission. Now, we've heard a lot about droplets from sneezing and coughing, etc., but can the virus be contracted through the air? Let's say if someone infected simply breathes on you.
Over to Dr. Yaffe.
Sure. I mean, if somebody breathes right on you, there probably are microscopic droplets. I mean, if you're close to them, that you wouldn't necessarily see. For example, if they're talking or shouting or singing or whatever. But that is not the same as airborne. That is still droplet or contact. And of course, we have to remember also that people can touch things, and then the virus can survive on those surfaces for sometimes hours or even a day or two. So cleaning surfaces is also very important.
Follow-up?
And my follow-up is, we heard the federal government implement the mandatory 14-day quarantine for anyone coming back from travels. We're days from people landing. So was the federal government too late on implementing this mandatory 14-day quarantine, and just your views on that?
Well, you know, they did come out first with from Dr. Theresa Tam with the quarantine order for people symptomatic coming back who arrive in the country and are symptomatic would have that time period. We've done the quarantine, 4 cohorts in Ontario on behalf of the federal government, 3 at Trenton, 1 at the NAV Canada Centre related to cruise ships. In there, we were anticipating some stronger ones. As you remember, in Ontario, we already asked people traveling, whether you're symptomatic or asymptomatic, especially because they're driving across the border in there, because we assumed that people flying would not be allowed to fly if they were symptomatic. In that, we asked them to quarantine for 14 days and in self-isolation anyways. This only but strengthens that. Whereas some provinces had less strict orders in that regard, this makes it a pan-Canadian approach, effective at all borders, both land and air and water and rail.
Next question
is from Jack Moon at Queen's Park Briefing.
Hi, doctors. I've been reading a lot about workers like cleaners and grocery store workers who are dealing with personal protective equipment. Do you think they're well enough protected during the pandemic? Does the province need to provide more PPE for them?
It's a good question, and we talked about that when they're doing these essential businesses in there. And I know I've gone and looked at to see, and I've been very impressed at what different owners of retail stores, groceries and otherwise, have set up with the barrier by the cashier. So there's a physical barrier. They're very attentive to the, I guess people call it the two-step, back and forth with the customer, and handle that, trying to use much more tap methods if they're handling cash or money, wearing gloves in that regard, and trying to keep the physical distance, trying to minimize the number of people in the establishment, spacing people out as they wait, seeing people with more vulnerabilities and certain hours ahead of time, and trying to handle that. So I think I see a lot of creative ideas. I see a lot more ordering online. I see a lot more delivery to people in houses and stuff, so they don't have to go out. They pay ahead of time, so there's no handing over at the door most of the time. It's just left on the doorstep with a doorbell. So I think everybody's doing all sorts of great ideas to make sure that essential materials are delivered, obtained by people, especially those in isolation, so they don't have to go out, but they don't have to feel pressured and compromised because they can't get what they need for the basic necessities of life. So I feel they're doing a good job, and we continue to ask them to address that, as the Premier announced, that the workplace would be adhering to the physical distancing, social distancing, and I think everybody's working full out to do so.
Follow up?
Is that enough, though, when you think of people like cleaners, sort of on the front line, coming into direct contact with some of the people who have touched and gotten dirty? Do they need more personal protective equipment instead of these big solutions in the stores and whatnot?
Sorry, Jack, that wasn't really clear. Can you say it again?
Sure. So when you have like cleaners who come into direct contact with things that people have gotten dirty, do you think that people working those jobs need more personal protective equipment?
Well, as Dr. Yaffe said, since it is droplet spread, if they're wearing gloves and proper covering and uniform and that, and they're using wipes and materials to wipe down and clean with, they should not come in contact as long as they don't touch the stuff with their gloves and then put their hands in their eyes or mouth and face. So they're going to have to be pay attention, because even if I've experienced, there's a lot of things you do you don't pay attention to, and you don't realize how often you do touch your face and your hands, especially if you're out in a public setting where you could have, as Dr. Yaffe alluded to, touched surfaces that might have viruses on them. So it means a time really focusing on hand hygiene, lots of hand washing, use of the alcoholic-based hand rubs. So it's that attention to that, and like staff who do that have to be, just like someone doing a very dangerous job with occupational safety, have to adhere to strict standards. This is the time they have to adhere to those strict standards while they're focusing on the job.
Next question.
From Phil Perkins, CHCH News.
Hey there, doctor. Just wondering, why is the recovered stat still in single digits? Is that because the tests are still in the lab and they're backed up from testing people to see if they have COVID to begin with?
Well, that is a good question, good observation. Up till now, up till recently, we have said that in order to consider a case resolved, we need to have 2 lab tests that are negative, that are at least 24 hours apart. And that is the criterion that has been used for those small number of cases that are listed as resolved. Of course, as you know, there's a lot of lab tests that are being tested, or being required, and have to be prioritized. And so those tend to not be prioritized. So in looking at the evidence and working with Public Health Ontario, we have just informed the public health units that they can use a different criteria for resolving a case, and that has to do with if the case is not hospitalized, they're not a healthcare worker, they recover, they feel fine, and it's been 14 days since they became ill, we're saying they can be considered resolved. But so our health units now are going to go about determining how many of the cases are resolved, and our number of resolved is expected to go up.
Follow up?
And we're getting some stories from patients who have traveled to the States. They have fevers of 108, and they have the symptoms, but are being turned away for tests. Is that just a resources issue?
So we're hearing from these are assessment sites in there. They'll carry out the self-assessment tool, and certainly if they've had the travel history combined with those very much important symptoms of fever, could be body aches, and cough or shortness of breath, we would call those definitely by clinical mandate a case that would have to do the isolation at home. When they go to the assessment sites in there, it's dependent on how severe the symptoms are. If they felt that they could manage them at home, and they could always come back if they get more severe, they could be assessed and then, of course, referred to an emergency department or a hospital for further assessment and possible admission in that regard. So we don't want people going to the emergency department or to seek admission when they still have we consider symptoms that could be managed in a home situation, knowing that we're saying you cannot come back. If it does exacerbate and you get worse, you can call telehealth, or if need be, you can call the assessment center or the other purposes and be taken to the hospital either by yourself or call ambulance ahead of time and note that you have that travel history and that you are in the minds of either your self-assessment tool or from talking to your healthcare provider or with telehealth a probable case of COVID-19 and get the care you need when you need it in the proper setting when you have to have all that supportive services potentially in an emergency department and from admission.
Next question.
From Miranda Antissel, Global News.
Good afternoon, doctors. So you briefly touched upon the outbreak at a Toronto nursing home. I'm just wondering, can you go into more details about what exactly officials are doing to address this and what's being done to prevent this happening at other long-term care facilities?
Well, I can speak to what happens in general when there's an outbreak in a nursing home. I'm not sure about the specifics of individual nursing homes, although that information could be made available. So obviously the first thing is that standard infection prevention and control is really important. We've put some controls on admissions and visitors, limiting the number of visitors and so on, making sure all staff are screened before they go in. If they're sick, they must go home. But if there's a case identified, obviously the case needs to get adequate care, but they also need to be isolated. We have to the local health unit works with the nursing home to identify close contacts, make sure that their clinical status and that they're isolated as well for the 14 days after exposure, increase cleaning of the place, more active case finding to make sure we're not missing cases.
Staff.
Yeah, I always forget that. And making sure that staff are what we call cohorted, so that the same staff are working as much as possible with the people who are ill, so we're not potentially exposing different staff. Yeah. So those are the standard things that are done.
Okay, follow up.
And for a follow-up to that, in terms of staff being given directives, if they are deemed critical, can you explain again, if they are deemed critical and they do work in nursing homes, long-term care facilities, and they have traveled abroad but they're not showing any symptoms, will they be in the nursing homes and long-term care facilities then potentially asymptomatic, taking care of these individuals?
Well, the directive that I gave out to the healthcare sector was the memo asking them to people who had returned from travel, not work, stay home in isolation. We know that there's different cities where asking different things and either requesting or requiring staff to come in. We're trying to assess that through our Ontario Health partners to understand why they would do that in the situation, especially because at the current time, the actual load in the facilities, as we said before, is not high. We've created that buffer, if you may. And if you think about the timelines we're talking about, because we asked healthcare workers and a lot of the hospitals and other institutions asked them not to travel, starting back on the 12th and 13th of March. So those 14-day period is coming close to an end now. So by forcing them to go back earlier, we said you could do so if you felt there's positions that were critical and that you would sit down with all parties. That includes with the professional and union side with management ahead of time to determine what those positions might be before you request a staff member to come back prior to the 14-day period if they're asymptomatic, and then what you do to monitor that person carefully, what kind of personal protective equipment they wear during that time they're undertaking those critical roles. But I would say if we keep those people out for the moment, that in a short period of time they will have completed their 14-day self-isolation period, and that kind of aspect would be a moot point in that regard unless someone still chooses to travel, maybe for essential or critical issues that I'm not aware of, because he said it's not essential travel. We prefer they didn't do any travel, but there may be some unique situations where someone feels obliged or required to go, and they would have to explain that to their employer.
Next question.
From Christina Tenaglia at CP24.
Hi, Dr. Williams and Dr. Yaffe. Thank you for your time, and I apologize if you've already addressed this. I wasn't able to access the news conference earlier. My question is about the potential for the Ministry of Health to use hospital beds for those who are, I understand, sick or recovering from COVID-19 or those most vulnerable. How will that help what you're doing? How necessary is it? How many hospital beds would be necessary, in your opinion?
So if I understand the question, we know that patients who do require admission, and that's a physician's decision in the emergency department, that they require supportive services during their time of assessment, because they may not have been assessed yet. They may require some supportive services that are not available in the home setting or in external settings, such as oxygen, so-called BiPAP and other methods, and up to ventilation and IV therapy and different things like that as they get more and more complicated. So that people just having it who are recovering, as we had some in the past, if you recall, were sent home when they did not need that kind of supportive therapy and care, and they continued the recovery in the home setting, and there are some of our resolved cases. So the people do not need to stay in the hospital just for that long period of the 14 days. If they're doing well and have enough supportive services to maintain their isolation in the home setting, then it might be better for them to go home and to recover there. But that's all assessed as part of their discharge plan.
Follow up, and I think this is the last question.
Okay, thank you very much, Dr. Williams. I'm wondering, based on your medical opinion, we continue to hear from construction workers across the province about their concerns not being able to social distance, unsafe and unsanitary sites, and of course Premier Ford has reiterated and has used very strong language saying if you don't feel safe, go home. This is still listed as an essential service. The Premier also noted, I want to bring to your attention, that things on the essential services list can be added or removed. Based on your medical opinion, should this be an essential service?
Well, I think the concern from the Premier is that construction, especially if it's for housing and other facilities for people's shelter, is still an urgent need. Some is hospital construction and other urgent and essential services that need to be put in place. So it's not, each one is separate and has different issues to be addressed there. I think the main thing I would look at there is that as part of the occupational health and safety, which they're, of course, asked to adhere to, can they maintain the physical distancing in there? Often I find they're working quite separated apart from each other, but sometimes you have to do things in tandem. How can you handle that? I think as far as hand hygiene, most of the time you're not dealing with those contaminated surfaces in there. There's other cleanliness and things that work with chemicals and stuff you have to have available, especially if you're working with certain products, and occupational health and safety has those standards. I think there's things they could provide, like packages of hand wipes and things like that could be useful in those settings. I think sometimes the times of most concern is when there's the breaks and everybody is standing fairly close together for periods of time chatting and talking. I think if they could just make sure they stand apart a little bit while they're having that break in that time period there, that would help in that situation. But across the overall picture, I think, as the Premier's alluded to, he feels that some are very essential to continue the need of housing and various other structures, including healthcare. But each situation is different and needs to be addressed and understood. How does that work, and can you maintain the physical separation and the social distancing while on the job?
Thank you, everyone.